I just throw. Videos. A very good afternoon, Dr. Arun, Rahul, Dr. Sharad,
Sir, good afternoon.
Narasimha.
Good afternoon, sir.
Very good afternoon.
Good afternoon, sir.
Good afternoon. We'll just take 30 seconds and then we should be able to start. Team?
Yes, sir.
Okay. Dr. Arun, special thanks to you for joining us.
My pleasure, sir. Thanks for inviting.
Very interesting set of slides. I liked it. Would like to. The way you link the first and the last slide is something good. I will borrow your last slide for my
No problem, sir. Definitely.
for my collections. Okay, Dr. Shubhi, can we start off then?
Yes, sir.
Okay.
Yes, sir.
Yeah. A very good afternoon to all of you. Warm welcome to another edition of the Mental Health Dialogues. First of all, let me put on record our sincere thanks to all the central team members and the Mental Health Dialogue team led by Dr. Prachet and Dr. Lata, who have been making phenomenal efforts to sort of get things together. I think this time they've been able to get in our Dr. Arun, who was earlier the co-PI, and unfortunately he's now not associated with NMHS2 in person. But Arun, a warm welcome and thank you for joining us. And then I'm sure this is one of your favorite topics. I think we have had several discussions as to how to expand on the services related to addiction and substance use. I will not get into more details. I will request the team to take over from here. As I see, Dr. Jayant also will be speaking to us. We've got a formidable set of speakers. With that, please continue to be part of this dialogue. The dialogue is going to give us that sort of an extra relief when we are thinking doing the NMHS2. It would give us some more lateral thinking, something more which will enrich us. So over to the team. I will just be a mute spectator. And thank you all the speakers, Dr. Arun, Dr. Rahul, Dr. Priyamadaba, Dr. Sharad, Dr. Jayant, Dr. Venkat Lakshmi Narasimha for all that support and cooperation. Thank you.
Thank you, sir, for those opening remarks. Good afternoon, everyone. I'm Dr. Rubal Coates, Program Coordinator, Public Health. A very warm welcome to today's webinar titled Mental Health Matters Addressing Substance Use. This session seeks to explore the intricate relationship between mental health and substance use and to understand how factors such as emotional well-being, environment, and social support influence recovery. We have with us a panel of eminent experts who will share their insights and experiences on this vital subject. Thank you for your presence and engagement as we begin this meaningful dialogue. I would like to invite Dr. Shalini to take over.
Thank you, Dr. Rubal. I'm Dr. Shalini, Program Coordinator, Public Health from the Central Team. I would like to take the opportunity to introduce our first speaker, Dr. Rahul Chakravarty. He is the Assistant Professor, Department of Psychiatry, PGMR, Chandigarh. His area of expertise is in addiction psychiatry, telepsychiatry, mood disorders, and public mental health. He has more than 50 publications and several awards to his credit. He would be speaking on bridging minds and recovery and understanding between mental health and substance use. Over to you, sir.
Good afternoon, everyone. Are the slides visible to everyone?
Yes, sir.
Okay, so thank you for inviting me. and I'll be talking about the topic. And as the time given to me is around 10 minutes, so I'll be talking about just the overview of the topic. That is the how can we link the mind and the recovery? That is understanding the link between the mental health and the substance use. So, as we all know, most of us are here. Most of us are mental health professionals, either psychiatrists, psychologists, or other mental health professionals. So we all understand that substance use and mental health, they both are deeply intertwined. And we, in the clinical terms, we call it as a dual diagnosis, which are often under recognized because we, in the OPD setup, we either focus on the psychiatric aspects more, and when we are sitting in a de-addiction setup, we tend to miss the psychiatric part of it. So that's why we need an essential integrated care for this. So as we all can say that there is no health without mental health, we can also say that there is no recovery without addressing both mind and the substance use. So the term was initially introduced in 1995 by WHO, and it indicates that the substance use disorder and psychiatric condition is co-occurring. Either they are preceding one after the another, or they are at the time of diagnosis, the both are present at the same time. So why do we want to discuss about it? Why it is important? Because it complicates the psychopathological status of a patient, leading to higher heterogeneity. It complicates the diagnostic framework. It makes it difficult to treat both the disorders, psychiatric aspects as well as the substance use disorder. And it often, we end up labeling the patient, even as mental health professionals, outside as well. So coming to the epidemiology, so I've looked up the data, global as well as Indian data. So we can safely say that at least 1 in 3 people who are having any mental health disorder, they also have some or the other type of substance use problems. And though the substance use disorder global diagnosis is around 2.2%, but the comorbidity is very high. It is as high as up to 80%. Like that's mental health condition and substance use disorder co-occurrence is up to 50 to 80%, and the persons with drug use disorder have another mental health conditions. So either the 50% patients who are having substance use disorder, more than half of them will be having some or the other mental health conditions, and the persons who are having primary psychiatric disorder, more than half of them may end up having substance use disorder. And as per our data, it is around comorbidity is around up to 90%. And the common substance use disorder and the combination of psychiatric illnesses, depression with alcohol use disorder, anxiety with benzodiazepines use, cannabis with psychosis, and PTSD with alcohol misuse of the opioids. So when we talk about the approximate prevalence, we find that alcohol and depression, up to 30 to 50% of the patients of alcohol use disorder also have depressive symptoms. And even in the Indian setup, the clinical study shows the prevalence is around 25 to 35%. Similarly, for anxiety and benzodiazepines use, as per Indian data, around 15 to 25% of the benzodiazepine misuse report prior to the anxiety symptoms, onset of anxiety symptoms. Same for the psychosis and cannabis use. Around 15 to 25% of the first episode psychosis patients report prior cannabis use, and similarly for PTSD and opioid misuse. So why there is a link? What is the link between these two disorders, or psychiatric illnesses as well and substance use disorder? It is a bidirectional relationship. Firstly, because of the common risk factors, which are several at the genetic level, predisposition, early childhood issues, biological predisposition, the brain areas involvement, and all those things. And the substance use can contribute to the development of mental illness subsequently, or mental illness may contribute to the substance use, which is like in substance use, like cannabis use can lead to a psychosis, a psychotic episode later in the adolescent or later adulthood. And similarly, we all know about the link of the tobacco use in schizophrenia patients. So, what are the shared common risk factors which both mental illness substance use share? Which are first is the genetic vulnerabilities, both at the genetic level as well as the epigenetic influences, which end up expressing as various proteins and other changes in the genetic framework. Brain region involvement, both reward functioning and other pathways, the circuits are involved in mental illnesses as well as substance use. Various, almost all the neurotransmitters, they both share the neurotransmitter, same kind of neurotransmitter, dopamine, GABA as well as epinephrine. And there are environmental influences, stress, trauma, and adverse childhood experiences. So what are the key implications? First is the diagnostic challenge, because both might have the overlapping symptoms. There is increased severity and chronicity, which lead to poor prognosis. The risk of suicide is higher. The adherence to treatment is poor, which essentially leads to dropouts and lack of insight. There are issues with the treatment as well. There are multiple drug interactions, increase in the drug level in the blood, leading to side effects, even the seizures, risk of misuse and diversion of the prescribed medications, and the psychosocial consequences also increase in multifold when both the diagnoses are present in the same patient. So, how do we face these difficulties? What are the difficulties? Let's discuss that. There is a poor motivation for treatment. When both the diagnoses are present, then the motivation also becomes very poor. And we as a psychiatrist often are a bit set which disorder should be tackled first, whether we control the psychotic symptoms or we control the cannabis use, or where to manage in the de-addiction setup or in the psychiatry board. There are risk of drug-drug interactions, and ultimately the rehabilitation also requires manifold effort from all the treatment all the treatment team, like the psychosocial, psychiatric, psychosocial workers, and all those. So, what are the goals? The goals are to address the acute and life-threatening conditions in the patients having suicidality and all those things. We have to promote the abstinence from substance use even while treating the psychiatric symptoms. We have to control the psychiatric disorders, address the comorbid medical illnesses, which will also come in play when we treat these two simultaneously. We have to guide the patient towards recovery, enhance the coping skills, and improve their psychosocial functioning, because if they don't get rehabilitated in the society, the conditions even worsens. So what do we do at the essential assessment? We have to do the detailed assessment, function assessment of the impact of substance use on relationship, housing, work, leisure activities, and personal goals of the patient. If there is any risk of self-harm, harm to others, self-neglect, or any bloodborne viral infections, assessment of motivation for change, whether patient want to change or not, especially in terms of substance use disorder, and treatment planning to address the motivation to reduce or stop the substance use, and if there is a pressing need, to include social needs, risk, medical, and psychiatric conditions. There are fixed treatment principles. We have to do it integrated care models. All the treatment teams, even if the medical comorbidities are there, they have to be treated simultaneously. It is a multidisciplinary team approach. Psychosocial intervention must also go along, and the pharmacotherapy, depending on whether the patient is having alcohol use disorder. After treating the acute withdrawal, we must go for a anti-craving management, and the long-term buprenorphine or other therapy the patients are taking opioids. We must include the family and educate them to reduce the stigma, and so that there is no more lapse or relapse, and there is treatment adherence wherever they are taking the treatment. We must focus on the recovery-oriented perspective, that we must focus on the strength of the patient, what there has to be some of the other strength which we can find out when we do the proper behavior analysis. Peer support and lived experiences integration like we do in AAs and NAs. Community rehabilitation with the help of our social work team, and conducting IC activities to reduce the stigma around dual diagnosis as a whole and about psychiatric diagnosis. So to conclude, there are lack of studies. So especially in Indian context, we need to have more work around these dual diagnoses and develop a robust evidence base. It is very important to treat the underlying psychiatric concerns, which can have trickle down benefits in improving substance use issues. And we must tailor and integrate the therapeutic components. These are my references. Thank you.
Thank you, Dr. Rahul, for the very insightful presentation. I request the audience to share their questions in the chat box for Dr. Rahul. We will take all the questions together after both the speakers have completed their presentation. Over to you, Dr. Ruben.
Next, I would like to invite Dr. Arun Kandasamy, who is a consultant psychiatrist for alcohol and other drugs and gaming disorder services at Fiona Stanley Hospital, Murdoch, Western Australia. He has studied as and worked at NIMHANS and was the head of Center of Addiction at NIMHANS. His areas of interest are addiction medicine, psychotherapy, behavioral addiction, and adult ADHD. He has about 38 publications. He would be speaking on the topic From Awareness to Action, Integrated Care for Mental Health and Substance Use. Over to you, sir.
Sorry. Am I audible?
Yes, sir.
Yeah, thank you. Thank you, organizers, for giving me this opportunity to talk in this forum. Thanks to Dr. Girish, Dr. Prachit, Dr. Lata, and the team. So the topic which was given to me was From Awareness to Action, Advancing Integrated Care for Mental Health and Substance Use. A slight background from which I'm currently working in a dual diagnosis setting, inpatient setting at this point of time. So have some idea about what's happening over here also, but I can't vouch for the entire Australian setting as such, but at least I have some idea about Indian setting. So thanks, Dr. Rahul. You have made my life simple because you've dealt with everything. So I can rush off fast and take up questions at later point of time. Just a customary to put disclaimer, I don't work with industry. And the pictures that you've used for academic purposes. This is an age-old discussion about where who came first, whether substance use came first or addiction came first. This might look odd, but then even the setting which I'm working in, the first two floors are mental health, and the third floor is addiction. When we triage, we keep fighting over here also about who would take up the cases and which one is important to be addressed. This argument is happening here also. So in a nutshell, as Dr. Rahul had covered, there are shared risk factors from trauma to stress to neurodevelopment vulnerabilities, and there are clinical overlaps in terms of having depression and anxiety disorders and other neurodevelopmental disorders, trauma disorders with substance use. And there are three proposed mechanisms in terms of these link. One is unidirectional causal association, where this primarily the substance use disorder leading on to mental illness. And there's a bidirectional or reciprocal causal association, where mental illness could lead on to substance use disorder, and substance use disorder could lead on to mental illness because of various issues, the underlying biological and psychological and social pathogenetic pathways. The third one is transdiagnostic relationships, which is being very well spoken at this point of time. And there are a lot of evidence which is coming up in terms of looking at substance use, mental illness, and physical illness as a continuum rather than looking at them in silos as such, like because of shared genetic and environmental causes. And also, basically, it doesn't seem to be that there's one substance use disorder is there is no mental health component to it, or mental health disorder is there's no substance use component to it. No, it all happens together. And in a developed society like Australia, it's hard to see anybody with mental illness without substance use, or with substance use without mental illness component of it. Like, the challenges, if we move on to, I'm of the opinion in India, the co-occurring disorders often they are undiagnosed or underdiagnosed. Maybe undiagnosed is a wrong word. Underdiagnosed and undertreated because the services are fragmented and there is quite a bit of stigma. We'll take it up later. In Australia, it seems like they are better diagnosed. But although I have written managed better, but I am still of the opinion over here that although the diagnosis happens over here, the treatment part, people are very comfortable in treating mental illness component to it, and not very comfortable about treating addiction component to it, because there are systemic issues in terms of substance use disorders were not under Department of Health for a very, very long time over here. It was handled differently. It was not under Mental Health Commission, and it is, I think, in the past decade it was included over here. So people are not very comfortable on that area, and the services are also limited when it comes for substance use disorder. Mostly it is handled in ED, emergency department, and then briefly managed somewhere, and then they go to rehab centers, basically long-term care centers. When it comes to treatment paradigms, I have put this is a very old slide actually. Generally in dual diagnosis or co-occurring disorders, we call it as the integrative treatment model. Sorry, I think it is written as model is the best one, but there are sequential treatment model and parallel treatment models also. Let's go through it one by one. Like sequential treatment model. What happens over here is you treat one first, usually substance use, because that constitute a little bit of emergencies and immediate issues which needs to be handled because people are in distress due to that aspect. And then address the mental illness component. Like, for example, it's like you finish the detoxification so that you can treat the anxiety or depression with medications and also therapy as such. The pros over here are that in a resource limited setting, for example, if it is in the GP or with the general practice setting, it's easy to handle these disorders in the sequential aspect. But unfortunately, it does have cons in terms of there's no comprehensive assessment and care over here, and there is always a possibility that the untreated condition will become worse. In the parallel treatment paradigm, both conditions are treated simultaneously, but not within the same team. Two different teams work on things. The pros are that there is no delay in addressing each of this, but the risk is that the care is still fragmented because being humans, we don't talk to each other and we don't communicate each other. And it is like treating the hair and nail separately and not the human as a whole. Example, the addiction clinic and mental health clinic working independently on the same patient. Unfortunately, even in developed countries, this is what is happening at this point of time because many of the the professionals are not very comfortable in handling, especially mental health professionals are not very comfortable in handling addiction-related issues. Integrative treatment model is the best model, no doubt. It's a single coordinated plan. Same physician handles both the issues, and when it is being handled together, the person is being looked at comprehensively, and a holistic approach is being taken forward, and that would definitely result in improved outcomes. But the cons are it requires skilled workforce who's comfortable with both substance use and the management of mental illness, which is very less number of people per se. Because in the developed country setting, there is another field called as addiction medicine, because most often they are being handled by addiction medicine. Even in the Western Australia, we have very few addiction psychiatrists, but we have many addiction medicine people where they could handle the detox part of it, but they wouldn't be very comfortable handling the mental health component to it. On the other side, the mental health professionals are not very comfortable handling this component to it. So it's no-win situation over here. And the systemic integration also is a difficult part. Yeah, it's a multidisciplinary assessment and management. It has the best available evidence towards treatment outcome. But what are the barriers to integrated care? Right? One is the systemic fragmentation. The systems are developed as a vertical arm where there are the substance use disorder program goes on one side, like the drug de-addiction program or the drug. I'm sorry, but this thing is the MSJ runs the addiction program. They're all and the NMHS, they're all going parallelly and they are not connected to each other. So there is a systemic fragmentation of the programs and the resources, and the workforce limitation in terms of the professionals' capacity in handling both. And there is a cultural stigma around addiction and the mental illness. When I was writing it, I was actually looking at both Indian and Australian setting. And what came in my mind was this stigma is not only with the patients approaching for treatment, it was also among mental health professionals themselves, that quite a few of them are not very comfortable in handling substance use disorder, in spite of having significant a mental health or mental illness related component along with it, like because of the stigma towards substance use disorder. For example, here in Australia, the eating disorder program will refuse to take any patient who's having substance use disorder, because they say that like substance use patients are not cooperative and they would not be benefited by the program unless they stop stuff and come to their program, which is to me it is not the right approach. But yeah, each protocol and each setting is very different. There are access challenges in terms of in rural area, the access is already less. Having such subspecialty of dual diagnosis becomes very difficult. Again, tribal, youth, and gender-specific barriers are always there. So I was looking at what could be possible solutions to such barriers. I would say solutions, there are possible solutions. Systemic fragmentation could be controlled by promoting policy convergence and inter-program collaboration. For that, the ministry should talk to each other because in India, to my knowledge, it's the Ministry of Social Justice is handling the drug de-addiction program, but the mental health is handled by the Ministry of Health. So both of them talking to each other and trying to run an integrated program is very difficult, but I think that's the way it should go. The workforce limitation, it could be handled by having training platforms which can train people like the Navans Digital Academy, and also looking at incentive for doing such kind of thing. The incentives could be money or in kind, whatever it. Cultural stigma around addiction, mental illness, launching public health awareness campaign, not only public health, even among the health professionals and mental health professionals in terms of addiction and what treatment and how holistic treatment helps these people. And again, the access challenges could be managed by telehealth programs. The telehealth program in Australia is running very well. Even the people who are coming to the metro side, they do have access to the telehealth, and people in different state also could access telehealth based on appointments. And the mobile outreach and culturally tailored services are also available. Yeah, this keep on it. These are the kind of helps which are available and they could be integrated. So the models of integrated care, which I was thinking were like collaborative care, for example, substance use and mental health integration in PHCs. So this is something which is coming to my mind because here it is the health system is GP-led health system. So the GPs are handling almost, I was told yesterday, I was talking to an RACGP member, and they were saying that like almost more than 60 specialist illnesses are also treated by GPs here. After the assessment and management, it goes to the GPs, and the GPs take care of the management part of it. There may be pitfalls over here and there, but then at least a minimum standard program is available for everybody. And co-located services like in PGI, AIMS, NIMHANS, where what happens is there are both addiction facility and the mental health facility are available. So a good service could be provided. But this is a vital elephant, I believe, because this cannot be present in every place apart from the tertiary care centers. Yeah, I'm talking from a generalist perspective, not specifically working in a tertiary care center. The case management approach through ASHA workers and peer support and community health workers, this would take the care to the local community, and early intervention would be possible. And again, digital innovations through various agencies would be good. So in summary, multimorbidity is a common in psychiatric disorders, including substance use disorders, which is also brings up to the NCD component, which we have not addressed here. Treatment paradigm needs to be more integrative and multidimensional for a better outcome. But based on each setting and the facilities which are available, we can mix and match. Although when I was in a tertiary consider, I was thinking that integrative care is the best care and that should be provided everywhere. But in resource limited setting, even if it is sequential treatment is available, it's good for people and let it be available to them. So when it comes for call to action, some of my colleagues at NIMHANS may not agree with me, but align the policy and practice. I would say like converge the NMHP and substance use program where the community is getting the maximum benefit, not people who have access to treatment. Right now, we are able to deliver service to people who have access to treatment, but it is not reaching up to the end user in the rural or in the areas where such kind of access is not there. So the best is to converge the national programs on the mental health and the substance use as such, and empowering the providers at every level, from the GP level, from private practitioners to the mental health professionals, health professionals, in terms of management of both mental illness and substance use, would make them comfortable to address it. So awareness is the first step, but action is the bridge to recovery. With this slide, whoever comes first, right, be ready. Yeah, to summarize, multimorbidity, mental illness, substance use, and chronic disease is the norm and not the exception. Thank you.
Thank you, sir, for your informative presentation. The floor is now open for questions.
Hello. Am I audible to the speakers?
Yes, Dr. B. Yes.
Yeah. Sir, I have got some direct questions here. I think participants are sending direct question to us. I'll just read it out so that speakers can take it up. The first question came is, when we say integrated care is essential, what does integration actually look like in a resource-limited government sector? Arun sir, would you like to take it up?
Yeah. See, in resource limited government center, I would say that integrated care actually mean that the first level is to understand that 60% of any chronic illness is directly or indirectly associated with substance use disorder. Right? This is one of the research in the past from NIMANS which came up. If we think of that, right, while we are treating gastritis, while we are treating pancreatitis, while we are treating diabetes, hypertension, we are also going to ask for alcohol use, tobacco use, right? And that is an integrative care, right? Not necessarily always think of having an occupational therapist, psychologist, social worker, and all of them are going to provide psychotherapy and recovery-oriented approach. That may not be possible over there. But what would be possible is to give an integrated care in terms of understanding the person as whole, what problem and distress with which they are presenting, and how to treat that aspect. I would consider that's as the best approach in a resource limited government setting.
Okay, sir. Thank you for the answer. There are a few other questions which are there in the chat box. I'll read it out for the convenience. Divya Bharti is asking, when treating patient with dual diagnosis, substance use disorder and another psychiatric conditions, what are some key consideration for developing an effective treatment plan that address both conditions simultaneously? And how do you prioritize interventions?
Dr. Rahul, would you want to go
Dr.
with
Arun?
this, or you want me to address? Okay.
Building
I would, yeah. Please go ahead, Dr. Rahul. Yeah.
I thought you can have a last word, sir. I think, like I also discussed, when we have both the things together, and like if there is an emergency, patient is coming with DT, he has comorbid psychiatric illness, whether it is psychosis or any other severe mental disorder. So our focus will be treating the emergency there. We'll be treating the DT, then admitting the patient. Then at the same time, we can, when the patient is stable, we can focus on both the diagnosis. And similarly, if the patient is coming with a suicidal attempt, then our focus should be to warrant that to secure the patient, to have it, provide him a safe environment, and then after stabilization, we can focus on the substance use as well as on the psychiatric illness. We often even in the tertiary care setup, like some disorders like tobacco use disorder and all those things, we don't even think of treating that. And patients are also not in a phase of preparation, or they don't even consider it as a problem. So if we work on the emergency and when the patient is stable, we can work on both. I think sir can also add about the priority and
You covered it, Dr. Rahul. Like there are the most important component is a comprehensive assessment, right? Shouldn't look at whether this is an addiction patient or it is it's a mental health patient or a physical health patient, like two holistic assessment of the patient, which includes understanding where this particular behavior has come from. Substance use is also a part of a behavioral paradigm, like say mental health and substance use. These are manifestation of a pathological behavior. So where did this came from, right? What the vulnerability this person had. Sometime you may not be able to find it, but at least our mindset should look at where did this originate from, right? I have a delusion that without underlying psychopathology, nothing will develop. So it is to understand the vulnerability first, right? And what tipped off them to this particular phenotype getting expressed, right? And then this particular phenotype and the consequences which arise out of this phenotype. If we have a better understanding of this, then that will help us to make a call, which is the most distressing symptom which we need to address. Not because it is a sequential treatment, but if you address the distressing symptom first, you will develop a extraordinary rapport with this client. And the client is going to stick on to you in terms of continuing this management for a long period of time, which most of these clients would need because it's a chronic recurring and relapsing disorder. Thank you.
Thank you, sir. Here we move to the last question that is there in our chat box. The question is being asked by Radha. She is working in perinatal mental health setting, and she wanted to ask a question related to pregnancy and substance use. She want to know how to address mental health issues and substance use during perinatal period. So the question is open to both of you.
Like in the pregnancy, the substance use is continued. Again, like Sir has explained about the management, it has to be again a multidisciplinary team. The obstetrician, the pediatrician, or the neonatologist will be looking after the child after the birth. The psychiatrist, even the psychosocial worker will be who might have to visit the patients after their ANC visits. And in the village setup, even the ashas, all these people will be involved in the management. So, and we cannot say that whether it is just the first trimester, so alcohol is harmful only in the first trimester. It is throughout the pregnancy, the harm is there. So we have to work on that. First, the prevention aspect. If the patient is coming to you with an alcohol use disorder proper, then management of the acute condition with the in liaison with the other doctors is a priority. Sir.
No, I think Dr. Rahul had covered everything. So in this setting, we get very serious substance use disorder and mental health issues in perinatal period and postpartum period also. It's very difficult to handle, especially when it comes for initiating OSTs, second trimester, third trimester, treating meth use disorder. They'll end up with us. It's quite difficult. One of the most important thing in this is at every step you need to involve the patient and the family and address the risks with them, right? Apart from what Dr. Rahul had said, that liaising with the involved in the care is very important. Along with that, the family and the client need to be aware of the risk at every level, even to it also, because at certain point of pregnancy, for example, we get people who are 34 weeks pregnant. Now, 34-week induction with respect to buprenorphine or methadone, it has its own difficulty, right? There could be a precipitated withdrawal, and that could result in fetal distress, and they have to go for an LCS. So at every step, the client and the family need to be involved and they need to be aware of the fact that there are risks involved in both treatment and continuing substance use, right? What's the best way to go forward, right? The reason why I'm saying is that this is quite a bit of legal conundrum and ethical conundrum in this setting. So being aware of it is important. Thank you.
Thank you so much, sir. Here we come at the end of our session. I would like to again thank Dr. Rahul and Dr. Arun for presentation and for answering all the questions. Here we move to the second session, that is panel discussion. Now I would like to request Dr. Lata K, Associate Professor, Department of Mental Health Education, NIMHANS, to take it over. Ma'am, please.
Am I audible?
Yes, ma'am.
Yeah. Very good afternoon, everyone. I would like to thank Dr. Arun and Dr. Rahul for their engaging and insightful sessions on the importance of integrating mental health and addiction and also discussing on how we can actually propose or think about integrated models and how it will actually help in taking forward today's conversation on the important aspect of mental health and addiction as part of mental health dialogue. So today's panel discussion on the topic Together in Healing, Reimagining Support for Mental Health and Addiction will involve 4 panelists, and I would like to invite all our panelists. So first I would like to invite Dr. Sharad Philip, who is a faculty assistant professor at the Department of Psychiatry from AIIMS, Guwahati, Assam. Dr. Sharad is an alumni from NIMHANS, and he has also completed his postgraduate diploma in family medicine from CMC Vellore. And his areas of interest are in the area of community mental health, substance use disorders, rehabilitation services with mental illness, and also developmental disorders. And he has a lot of publications and awards and honors to his credit in the area of mental health and rehabilitation. So I would like to invite Dr. Sharad Philip, and next I would like to welcome Dr. Jayant, who is an assistant professor at the Center for Addiction Medicine, Department of Psychiatry, NIMHANS. So Dr. Jayant has completed his MD from JIPMER, Pondicherry, and DM in Addiction Psychiatry from NIMHANS, Bangalore. His areas of interest include vulnerability to addiction, co-occurring mental illness and addictions, behavioral addictions, and psychiatric genetics. To his credit, he has more than 75 publications, and some of the salient awards include Torrent Young Research Scholar Award in the year 2013, and he has also received the DNB Gold Medal in Psychiatry in the year 2014. So we are honored, and I welcome Dr. Jayant to this panel. Next, I would like to welcome Dr. Venkatalakshmi Narasimha, who is an assistant professor at the Department of Psychiatry, Center for Addiction Medicine, Department of Psychiatry, NIMHANS. So Dr. Narasimha is an alumni from the Department of Psychiatry, NIMHANS, Bangalore. He has completed his DM in Addiction Psychiatry in the year 2020. And some of the salient awards to his credit include Best Researcher Award from AIIMS Diogar in the year 2023, ISAM NIDA Fellowship in the year 2019, and also the DST Travel Grant from the World Psychiatric Association Travel Grant in the year 2017. So welcome Dr. Venkatalakshmi Narasimha to this conversation today. And last but not the least, I would like to welcome Dr. Priyamdaba Behera, who is an associate professor from the Department of Community Medicine and Family Medicine at AIIMS Bhubaneswar. So he has also completed his MA in Population Studies from IIPS Mumbai, and his areas of interest include chronic disease care, tribal health, epidemiology, and primary healthcare and innovations. So some of the important awards and recognitions to his credit include Dr. Sushila Nair Memorial Young Leader Orator Award in the year 2024, the Presidential Appreciation Award by IAPSM in the year 2023, and also he is also the recipient of Intermediate Grant Research Grant by ICMR in the year 2024. So I would like to welcome Priyam Daba Behera for today's conversation.
Thank you.
Thank you.
Yeah. So I think the conversation by Dr. Arun sir and Dr. Rahul has already set context to today's discussion on why it is important for us to look at models, and also why we are actually here discussing about having like parallel conversations around mental health and addiction recovery. And today's panel also focuses on initiating collaborations, reduction of stigma, and also building holistic approaches that promote lasting healing and resilience. So I'll start my question by asking Dr. Sharath Philip first. So Dr. Sharath, what are some of the current programs which are available for managing substance use disorders, which includes programs and services currently available within the healthcare systems and also within the mental health care systems? And what gaps do you see in the implementation of the same?
Thank you, Dr. Lata, for that question. Am I audible and clear?
Yes.
Yeah. Thank you to the organizers for this opportunity. It is quite an august forum here, and I feel that a lot of things, whatever I say, may be much better. It may be much better for others also to add on to that. And so starting with something that Professor Kandasamy has already alluded to with regard to how substance use disorders are looked at from a different lens. The localization within India under the Ministry of Social Justice and Empowerment tries to probably build on addiction as a social problem. By doing so, in my opinion, it locates substance use disorders as only within the person, and maybe to some extent some things in the environment. This deprives a lot of family members of the support that they need. Locating substance use disorders as a character problem within a person also limits the interventions, limits the access, perpetuates the stigma, propagates the inaccessibility of the services. That said, there have been some changes that we are looking at. So some of the things from the Ministry of Social Justice Empowerment, one is the Nasha Mukt Bharat Abhiyan. So this is the large rubric, the umbrella from where we are seeing a lot of things coming from there. Now, when we look at it from the from how we go from what we identify as a problem, and then we look at, okay, how do we want to understand and solve this problem, and then we try to implement something on the ground. So these three levels of let's say the policy, the plan, and the practice. Now, policy as being an aspirational set of ideals, the things that you want to see on a horizon. You can say all of this, and so probably the Nasha Mukt Bharat Abhiyan is something of that kind of a thing. A very aspirational goal where you are looking at a substance-free society. That said, from there, the programs are there. There's a National Action Plan for Drug Demand Reduction. You also know that there's a lot of work being done with regard to supply reduction. There's a lot of work being done for harm reduction measures as well. Now, why do I say these three terms? We're looking at trying to help the persons with substance use disorders by treating them, hoping that it results into abstinence, it reduces the demand of the drugs, and so this will just fall out of favor. We're also looking at trying to use law enforcement towards, making sure that supply is not available. So you want to strengthen your borders, you want to have drug seizures. These are the big ticket things that you see as headlines and tickers on your routine news events as well. So a lot of agencies are involved there. Then you're looking also at harm reduction. You have an understanding now that there are some people, whatever you do, you may not be able to get them to come to that abstinence level. It may be more sensible, more prudent to reduce the harm that is associated with that. So then you have your National AIDS Control Program, and then through that, the OST centers, the needle syringe exchange programs, and all of these things which are there. So in a span of this, what I'm trying to explain to you, it is so intersectoral that there's not just one program that looks at substance use disorders exclusively. That I feel is also its weakness and its strength. The realization is there that it is affecting so many health conditions. It is affecting so many aspects of social environment. Yet we don't have a unique or direct programmatic focus on it. Now, as Professor Kandasamy also mentioned about the integration, that word is so loaded. It requires that the understanding of substance use disorders be brought in within the rubric of non-communicable diseases along with mental health conditions. There is no sense of trying to dissect the two at this point of time in India with the evolution of the health systems that have happened here. So going ground up, there's a lot of emphasis that needs to be placed, and there is some amount of work going on in that regard. Professor Penegal, who is also part of the first and also this NMHS, is one of the mentors for something that the ICMR is doing and trying to build up a decision support system to empower general practitioners at the bottom up to work on substance use issues. That said, there are some other programs which are available for those of you in government settings. There's an addiction treatment facility scheme through which you can apply and get some funds, you can get some staff. So one of the workforce aspects gets taken care of. You also get some medications to be able to dispense for patients for larger institutes. There's now a program, there is a program or there which is still running. We're not sure of whether the applications are still open or not. That's the drug de-addiction program. Now, as regards co-locating, again, one of the things that we were talking about, one aspect that is missed about here is the recovery and the rehabilitation. We hear a lot about the private centers having these rehab centers. You send a person to rehab, and rehab means you put them in an environment, cage them, and you deprive them of the substance, and then everything becomes all right. And you've demonstrated abstinence, and the person then comes out saying that I really don't need this substance. It works, it doesn't work. And most of the times it actually does not. It probably this is a need for the families, which has not really been realized by the health system at this point of time. It is fraught with human rights violations. It is fraught with a lot of regulatory lapses as well. So net, when you're looking at the span of programs, it's there across and it cuts across so many different sectors. We also have certain aspects of youth empowerment where we are actually directly focusing on substance use and delaying or at least deferring experimentation of substances through well-being projects which are being taken up across the country as well. That's the long and short of it. Back to you, Dr. Lata.
Thank you. Thank you very much, Dr. Sharad, for actually throwing light on a lot of these important aspects, including the limitations and also the advantages of having multiple programs, and at the same time also like highlighting what are some pitfalls with having multiple programs and what are some lacunae which we are actually facing with all these acting and also suggesting some important aspects in terms of the integration models, in terms of around the umbrella of NCDs, larger umbrella of non-communicable diseases, and also highlighting a lot of these regulatory concerns when it comes to the private players or even with respect to the rehabilitation centers in addiction treatment. So thank you very much. And a follow-up question to you, if you can just highlight how can these services be strengthened to promote more compassionate and stigma-free services, so that these integrated care for individuals with both mental health and substance use challenges. It can offer an integrated care for individuals with both the mental health and substance use challenges.
Well, I think that has been most expertly dealt with by Professor Kandaswamy when he mentioned about integrating it. So the same person, when you are looking at the same person is offering care for substance use services, substance use disorders, as well as for mental health conditions. Now, maybe we could take it a step further. I answer this with some, with some trepidation and a lot of humility here. I may just be one healthcare professional who may be seeing one aspect of things, but there's a lot more consensus and consolidation of stakeholder inputs that's needed. Probably we should be looking at the same person treating NCDs, substance use disorders, and even mental health conditions to begin with. And then, we look at which of these things are then needing further expert management. The second thing is that, many a times there is a sort of a trade-off. Okay, at least, he's taking only tobacco. He's not taking alcohol. So the diabetes is a little bit better controlled. This sort of a trade-off, or this sort of reaching the halfway mark and feeling some sort of satisfaction at having achieved a goal, so to say, may be something that is self-defeating, because we're still risking a lot of vascular insults and long-term morbidity and all of those things that are coming. So probably our goals would have to align towards a very appropriate, balanced management of all three sets of conditions. So that's with regard to the goals. The first one was with regard to redefining integration, and the third thing was with regard to you mentioned about compassionate, stigma-free. Well, this is something that has to be taken up at multiple levels, and when we are talking about it, even as we talk about it now, let's also realize that there's lots of people talking about substance use conditions out there who do not use these frames or explanatory models. They would rather look at it as, this is something in their mind, ये सब सोच में है, ये इससे वो शराब करवा रहा है, शराब की वजह से ऐसे हो रहे हैं. All of these are, somehow locating the problem within the person, and by implication necessitating that the person is responsible and the person only should do. Ultimately, this is something that really does not work. And the last thing I would say, strengthening is required with regard to the families. These are people who are our largest informal care resource in the country. There's a lot of burden that is there on them. Because of the the chronic relapsing, remitting nature of things, they really don't understand that, it's going to be something that's going to have a lot more falls before someone really, is able to stand for a sustained period of time, or maybe even recover for a sustained period of time. So these discussions, I feel, should happen more in the lay audience as well, where we're looking to empower families and we actually counter the narratives where it's located within the character, or the personality, or ye to aisa hi hai, or those kinds of things. Yeah. Back to you, Dr. Lata.
Lata, you are muted. Dr. Lata, you are muted.
Yeah, thank you very much for highlighting all those important points, including the role of family members, caregivers, and also the larger burden in terms of not just about the addiction and its management, but also in terms of the stigma, and also about the overall impact it is actually having on the individual and also the society at large. So thank you very much. I would now like to move to Dr. Jayant. So Dr. Jayant, with your work, if you can throw some light on some of the important key barriers and enablers for effective collaboration between mental health and addiction teams.
Thank you, Dr. Lata. So I think I can probably speak from the Indian perspective. There are different combinations in which mental health and addiction treatment are delivered in India. I think we need to look at all of these different levels. We'd actually reviewed this about a year or two ago. I think many of our collaborators and many of our colleagues from different parts of the country had talked about the kinds of mental health and addiction services that are delivered in India. So broadly, you have this, like the mental hospital GHPU setups, so the general hospital psychiatry units. Actually, in those settings, mental health and addiction is typically integrated because, as Dr. Arun had mentioned, most often in India, psychiatrists are the ones who deliver both mental health as well as addiction treatment. And so the barriers or the challenges in that kind of a setting are primarily related to, and this is something that Arun sir had alluded to as well, is variation in training of psychiatrists. So psychiatrists are variably trained in addiction psychiatry. So not everyone is very comfortable with being able to adequately manage different kinds of problems related to addiction. So that's the major challenge in those kinds of settings, right? In addition to that, then you have what Sharad spoke about, right? That there are a lot of specialized de-addiction centers that, particularly in the recent past, through many of these schemes have kind of come into being, right? So these include the MSG sponsored IRCAs and addiction treatment facilities. So these are in a way specialized treatment facilities which are standalone from other mental health services as such, right? And of course, Ministry of Health supported, you have NACO OST centers, where again, they're primarily the people who man this are medical doctors and some support staff that are there, nursing as well as some counselors and so on, right? There, the issues of integration are much more because obviously mental health is not inherently part of the training of any of these people who are there, who are manning these centers as such, right? So there the issues are slightly more. You have issues related to under recognition itself. So very often in these centers, and we do quite a lot of training. I mean, Narsimha, myself, many of us do training for at least say like NACO OST centers and things like that. So when we go there, I mean, actually you have to train them in basic addiction management itself. When you're talking about actually also helping them to be able to understand and recognize mental health conditions which are co-occurring with addiction conditions, that is even much more challenging. In these settings, apart from the lack of training, the other challenge is also that staff turns over very often in these kinds of facilities. So these specialized de-addiction centers are, I mean, you will not have people who stay for a long period of time, right? And then in addition to this, I think Sharad also spoke about the fact that there's this very large unregulated sector where, I mean, things are obviously much more problematic. So those are the private and other unregulated de-addiction centers. And there, though, I mean, talking about integration is, I mean, we are very far from that at this point of time, right? So just, I mean, India is a very diverse place. We have so many states, so many languages, so many countries. So similarly, we have a lot of different ways in which treatment is delivered. And so these are some of both the barriers and therefore are also some of the opportunities and challenges that are there to look at integration.
Thank you very much, Dr. Jayant, for sharing important points related to lack of training, attrition among the staff, and also having a lot of these unregulated programs or even centers, and also with having a lot of challenges in terms of diversity in our culture itself. So I think like agreed with your point that still there are a lot of challenges in the ground, that is like practical concerns in the ground level, and we need to actually look at sorting these at the initial level, and like looking at the other aspect is actually a larger picture for us now. So moving ahead, how can digital tools or telemedicine enhance continuity of care for dual diagnosis patients?
Yeah, so again, I think a lot of this has been spoken about already. So, but I'll be very, very brief, just a few points. See, I mean, One thing is, we know that co-occurring mental health and addiction conditions, they are very complex, right? They are the kinds of conditions which require a lot of inputs in terms of treatment at an individual level, apart from whatever are the other treatment services that are required, right? The second point is that treatment retention, and this has been emphasized by many people, that is the key, right? In all addictions, but specifically in situations where there is co-occurring mental health disorders along with addictions, right? And so therefore, I think there is a great role, and I think there's a very significant part that has to be played by various kinds of digital initiatives. I'm going to touch upon two things, just emphasize two things that are being done. So one is, of course, related to digital training, and this follows on from the point that I made, that there is a lot of variation in the standards of how people treat people with addictive disorders and co-occurring mental health and addictive disorders. And so I think one thing that we've been doing, that's obviously being led by Professor Prabhat Chand for many, many years now, I think starting in 2013, 2014, now it's been more than 10 years, is the VKN NIMHANS ECHO. Now, of course, it's broadened to the NIMHANS Digital Academy. And I think one thing that has really helped, and I know this because we have been part of many of these training programs at varying levels, both for basically primary care providers, but now over the last 5 or 6 years, we've also been training mental health professionals, including psychiatrists, in being able to upskill themselves in more complex addiction management as such. In fact, we're going to be starting one more cycle of that in November. And I think that is one key initiative about looking at being able to kind of standardize these variations that are there in what would be the kind of optimal care that has to be developed. So that is one way in which digital initiatives work. The other thing which obviously Narasimha has taken the lead on and done a lot of work on is the actual telepsychiatry itself. And I think delivering telepsychiatry services, I think, has a great role. And Dr. Arun mentioned that it's a fairly mature system in Australia. But I think being able to deliver addiction psychiatry care, particularly where treatment retention and people get lost to follow up a lot, I think using telepsychiatry, using aftercare, both of which are things that have been done quite extensively at NIMHANS, at CAM. I think those help in being able to retain patients in treatment. It makes some of those problems related to inaccessibility a little less of an issue. And I think we've not formally looked at outcomes yet, and I think somebody's looking at that. I think Narasimha can probably talk a little bit more about that. But I think that would kind of help us to be able to actually get some data on being able to say that some of these digital initiatives actually help with being able to improve continuity of care. So, but I think it's extremely important. I think that's something which is definitely the way forward.
Thank you very much, Dr. Jayant, for highlighting those important points on the role of NIMHANS, especially VKN ECHO, in terms of training specialists, especially mental health professionals in the area of addiction psychiatry through various apps and even training programs, courses, and also highlighting on the importance of telepsychiatry to address the issues on accessibility and also about providing the continuum of care, because that is what is very, very important to prevent relapses and also to actually like hold the patients to be on treatment for a longer period of time. So thank you very much for sharing your insights. And I would like to now move on with Dr. Narasimha. Narasimha, what are the policy or system level changes which are the need of the hour to reduce gaps in mental health and addiction services?
Thank you, madam. I think thanks first of all for having me. And I think many of these things were already highlighted at various points of time by all these speakers. And if I have to summarize that there are a lot of verticals that we are looking at a policy level. One, for example, you have DMHP, then you have DDAP, then Ministry of Social Justice and Empowerment has this addiction treatment facility. And Dr. Rahul has highlighted that tobacco is something very much neglected. So there is National Tobacco Control Program. So multiple verticals are there, and these verticals don't talk between or talk less between each other. So there comes the integration between the mental health and addiction, or the verticals talking between each other is itself is less. So when you are talking about this integration with NCDs, that is much more less. So I think there are advantages of having different verticals because you have a focused approach, but there are also disadvantages that they don't talk between each other. I think that is something that over a period of time at policy makers are also looking into. Any ministry meeting that we attend, one of the things that is integrating, how do we talk between each other? So that is one opportunity which is a barrier at this point of time. And when it comes to the private sector, it's a completely a different ballgame. I think it doesn't come in the to some extent into this all these verticals and policy related things. Second thing is when it comes to the component that Jayant has talked about. When you look at a policy level, training is another important aspect. So if you see right now, 1 lakh MBBS graduates are intake at each year. So if you look at NMC curriculum at undergraduate, there is no training in terms of addiction, which is mandatory. So the curriculum is also very minimal. So it is very important to. I was in an institute where psychiatry is a separate special subject in undergraduate. Two institutes have psychiatry as an undergraduate. The amount of information that goes into and the kind of training that is there is completely different when you have a separate curriculum for psychiatry and addiction. So I think that is one important policy level issue that we have been trying with NMC is also to integrate or to have this curriculum into undergraduate training. And when it comes to postgraduate training, it is across specialties also it is less. At least in specialties which are related, there needs to have curriculum related to addiction. And when it comes to psychiatry training, I think Dr. Arun has highlighted, many of them have highlighted that even for a psychiatry training, some of the institutes have the privilege to have a separate addiction and have some training. But many, 90 to 95% of the institutions don't have such kind of privilege. So I think there is a gap. So that's where the gap at postgraduate is being filled by some of the courses which Dr. Prabhat sir runs, weekend courses. But that is not sufficient. That is not sufficient at this point of time. I think there is a huge scope in terms of expanding this training. If you have to look at a policy level, I think these integration, which is a aspirational thing, but at least training is something that can be, if you look at a short term at 5 years or 10 years down the line, that is one important policy decision or policy related changes that can bring in a lot of change. So these are two important points that I would like to highlight.
Thank you very much, Dr. Narasimha, for highlighting those important pointers on the role of having a standardized training or curriculum, both at the UG and PG level as part of NMC, because I think it plays a major role, because now we are looking at integration, and at the same time, to actually make it possible or to make it feasible, I think these are some important pointers. And also later, we could, based on these foundations, we could actually plan the integration models later on. So thank you for sharing your views on the curriculum aspects and also on the importance of decentralizing and having a standardized training curriculums. And moving on to the next question.
Hello, ma'am.
I request the other participants to please mute. Yeah. How can psychiatrists play a stronger advocacy role in shaping such integrated models of care?
Yeah, I think a simple point that I would like to add is to educate the fellow specialists. at least in terms of at a local level, in terms of doing screening, brief interventions, and referral to treatment. This is something that is done at a policy level. But as psychiatrists, I think we need to educate our own fellow specialists. If you are working in a GHPO setting, doing some training programs to educate your fellow specialists in terms of doing
Hello,
this
sir.
brief interventions and referral to treatment.
Sir, hello.
Yeah. So that is one thing that has been found to be useful across the world when the specialists, apart from psychiatrists, do this screening, brief interventions, and referral to treatment. That has been helpful. I think this is one point that I would like to emphasize on.
Thank you, Dr. Narasimha, for emphasizing on the importance of the advocacy roles by the clinicians. So I would now like to move to Dr. Priyama Daba. So, sir, how can community-based and primary care approaches strengthen early detection and prevention of both mental illness and addiction?
Thanks, Dr. Lata, for the question. I'm thankful to the Nimans and the team for the opportunity. And before going, am I audible or clear?
Yes,
My voice
yes.
is clear. Okay, Dr. Lata. Yeah, my colleagues like Dr. Venkat, Dr. Zain, Dr. Sarad had just spoken about particularly the demand side, the hospital-based care models and the integrations. But you need to understand the context. If you look at the two side of coin is as you look at from the Dr. Arun's words, the knowledge or the community awareness is the demand side issues. That is the demand side thing that what community need. And the second, the bridge is the supply side issues, primarily which is addressed by health system. So we need to understand both the context, the community perception as well as health system issues, supply side and demand side issues. Coming to the community-based diagnosis, we need to learn from the successful programs that we have run in the country. Look at the RCH model, where the institutional delivery has gone very much up. What has happened? Does the gynecologist deliver all the deliveries? We know that 82 majority of deliveries, normal deliveries are conducted by staff nurse. Only the complex, the cesarean sections or the complex delivery, the challenges that are taken by gynecologists. Similarly, the psychiatrist has to deal with the complex addiction disorder or complex mental health issues. The common mental health issues or priority mental disorder has to be treated at PSC or primary health care level. So that is one, like we were talking about undergraduate, postgraduate teaching and training regarding the treatment. For example, depression, anxiety, or stress management, that should be done at PSC or CSC level. That is one of the important things, that which is not happening right now. Coming to the community-based model, if you look at the community-based care, the social norm are very critical. Now, how does society think in terms of, we decide, as Dr. Sarad said, it is a social disease, addiction and social disease. When society wants, this is a social phenomenon, take a few drinks in a few occasions, or it is a disease, you need support system. Similarly, when it is a mental health issue, like in Indian setup, somebody is not shouting or majority of them did not seek care. The social norms and cultural norms plays a vital role. So the community health workers, because community health workers understand the cultural milieu. By the virtue of cultural milieu, they have a good understanding of cultural perceptions and what is the normal in the community, what is not. So basically, the ASA and community health worker is a very important for early diagnosis and the referral mechanism to the health system. That is very important. They need to understand the concept and the importance of mental health and addiction disorder. So that is important, but the most important is task sharing and task shifting. Task shifting from the psychiatrist to medical officer for the management of priority mental disorder, and task sharing for the early identification and referral in the system. If you look the staged care model, that article we have already wrote before, in staged care approach, we divide into 5 populations. One is well population without any disorder. The second is at-risk population. Third is mild, moderate mental disorder. Fourth is severe mental illness, and fifth is aftercare. The initial well population, we need to promote mental health, and mental health literacy has to be taken care of. There is a role of mass media, there is a role of social media, there is a role of community health worker, particularly stigma reduction and mental health literacy. These two play a critical role in the well population. Then at-risk population like community health worker, ASA needs to refer, identify early. That is at-risk population. Mild disorder, the health system at very primary level has to diagnose and treat, and moderate and severe has to taken care by tertiary system. When is referred back to the community, then the aftercare has to be taken. So that is overall a staged care approach with task sharing and task accepting, with a social norm, which is acceptable for mental health care and addiction disorder is very, very important in the current context. Thank you, Dr. Lata. You are muted. Dr. Lata, you are muted. Can you unmute? Yeah.
Thank you very much for your sharing your insights, Dr. Behera. I think we completely agree with the various models within the health systems, especially with RCH models, how we have been able to decentralize and also leverage in terms of having standardized training and also having good indicators in terms of maternal outcomes and also for the infant related outcomes. I think similarly, definitely we have a big role in terms of promoting mental health literacy and also to address at different levels, like I already mentioned about the continuum of care. So looking at the general population or the community at a large, and also looking at risk populations, and also as the last step of aftercare services, including the rehabilitation services. I think it is definitely going to impact with like when we are actually trying to address at all these important like points and providing the required services. So thank you very much. And a continuity question for you, Dr. Behera. What would a truly community-driven model of healing and recovery look like in practice?
Yes, if you look, Dr. Sharad has started the private rehabilitation model that does not work, that has a regulatory issue. But at the same time, we need to understand community-based rehabilitation. That is important. Community-based rehabilitation and continuum, integrating with continuum of care in state care approach model is critical. But at this, you need to require the technologies, the anchor in them. Like for an example, the technology plays a vital role, digital health, Telemanus or Neman's Digital Academy, whatever you say, but that needs to spread to the community, accepted by community, and demand supply side, that both has to go together. That is very critical. Community-based rehabilitation will be definitely very important. The rules of society acceptance more often, family and social supports are critical. For an example, we know that an individual is entry to a family, and family is entry to society or community. So that means something who needs support in substance use disorder or mental health disorder, the family support system as well as social support system are critical. They not only need for the early identification, they also require for aftercare. That as a continuum of care can be maintained. So that's all I think. Thanks, Dr. Lata.
Thank you, sir, for sharing those important points on the important community-driven model for healing and recovery. So we have now concluded with all the questions for our panelists. And if there are any questions by the participants, please feel free to unmute, or you can also share on the chat. We can take one or two questions. Please feel free to share on the chat box or also unmute and share. Shubhi, if you have received any questions, you can please read it out.
No, ma'am. As of now, we have not received any question.
Okay.
Thank you.
So I request the participants, if there are any questions, You can please unmute from any of the NMHS staff or the different teams. Yeah, I think we had exceeded our time, and since there are no questions, I would like to thank all the panelists for taking out your time and sharing your valuable insights with our participants. And I think this will actually help a lot of our the NMHS 2 teams which are actually working in the field, and I think it will actually help them to understand the importance of the survey which is actually going on in assessing the mental health and also addiction related concerns. So thank you once again, and I would now like to hand over back to Rubel.
Good evening, everyone. So, on behalf of NMHS2 Central Team, I, Dr. Divya, would like to extend our heartfelt thanks to our esteemed speakers, Dr. Rahul Chakrabarti and Dr. Arun Kandaswamy, for their valuable insights. And also, I would like to extend our gratitude to all the panelists, Dr. Sharath Philip, Dr. Jayant Mahadev, Dr. Venkatesh Lakshmi Narasimha, and Dr. Priya Madhava Behra for an engaging and thought-provoking discussion. Also, our sincere appreciation to the moderator, Dr. Lata, for guiding the session so effectively, and of course, all the participants for your active engagement and thoughtful questions. Now, I would like to request all the speakers and panelists to please turn on their cameras for a good group picture. Whoever is there. Okay.
Just give me a second.
Sure, sir.
Ma'am, the camera is disabled, ma'am, video. The video is disabled, ma'am.
Should be the participants are unable to switch on their camera.
Yes, ma'am. Not able to switch on.
Yeah, we'll just allow you.
I'll just, we just, hello, I'll just request only speakers and resource person to please switch on the camera for the photo. Yes, ma'am, I have took the picture. Thank you.
Thank you everyone for joining us today and for contributing this meaningful dialogue on mental health and substance use disorder. Thank you, and
Just a minute, Divya. Just a minute. I think Arun sir has joined now. He has switched on the camera. We just check with him. Arun sir, are you there?
Yeah, I'm there.
Yes, sir. I'll just pin you and click one more.
Button.
Yeah. Yes, sir. Done. Thank you.
Thank you, everyone.
Thank you.
See you. Bye.